Hello, ladies and gentlemen. This is Dr. Silva, and I'm here to talk to you about Abilify, aripiprazole. Abilify is a dopamine serotonin receptor partial agonist, but it's actually classified by many names. It is a dopamine stabilizer, an atypical antipsychotic, a third-generation antipsychotic, although sometimes it's included as a second-generation medication, and it's also referred to as a mood stabilizer. It's a great medication and it does a great many things. There are numerous dosage forms. It comes in a tablet, there's an orally disintegrating tablet, there's an oral solution that you can give children, and various injections. An immediate acting injection for acute agitation that could be used in a hospital setting, for example, as well as depot preparations where it's administered and then the medication is slowly released over a period of weeks to months. And there are at least 3 preparations. The FDA-approved indications depend on the dosage form. So, for example, the tablet may be approved for certain age groups and certain diagnoses, whereas the injections may be approved for usually a broader spectrum of disorders. But the primary target symptoms of Abilify, you give it if you are targeting the positive symptoms of psychosis. It is an antipsychotic, so it blocks delusions and hallucinations, as well as the negative symptoms of psychosis, symptoms like affective flattening. The affect is the expression of emotion, and these individuals with primary psychotic disorders, even in the absence of major depression, will have a blunted or flat affect. Alogia, which is diminished speech. Asociality, social withdrawal. This is not the same thing as antisocial behavior. This is being asocial, social withdrawal. Avolition, which is a failure of initiative. It's a failure of a person to be motivated and to begin and to follow through on tasks. And anhedonia, which is loss of pleasure or enjoyment in day-to-day activities. A person doesn't look forward to things, doesn't get excited. And this, of course, is also a feature of depression. Depression, which is very common in primary psychotic disorders. It's very important that the clinician rule out depression when they see negative symptoms. It also is useful for cognitive symptoms and for an unstable mood, treating both depression and mania. It's a mood stabilizer. And it's good also for aggressive symptoms in certain patient populations. So it is FDA approved for schizophrenia in adults, various preparations. It's also approved for schizophrenia in children ages 13 to 17, but that's the tablet form only. And, some of this is somewhat arbitrary. It's the same medication, but there are different delivery systems and different doses, and it boils down to what the manufacturers decided to study and the information that they presented to the FDA, because these different formulations, they have to all prove that they are effective in double-blind placebo-controlled trials. And so if they didn't run the studies for the tablet, for this particular disease and this particular age, then they didn't present that information to the FDA and they didn't get FDA-approved labeling. Of course, clinicians often prescribe off-label, so you don't have to have an FDA approval in order to use medication. But it's also approved for maintaining stability in schizophrenia. It's approved for both acute mania and mixed mania, so mania with dysphoria, depression plus mania, in the same episode in ages 10 and older. It's also approved for bipolar maintenance, again, various formulations as monotherapy, and the Abilify tablet is approved for bipolar maintenance as an adjunct. So if you're just using the Abilify tablet, then it's approved by the FDA in conjunction with other medications to prevent major mood episodes, including depressive and manic episodes, both. But if you want to use aripiprazole as monotherapy for bipolar maintenance, then there are other preparations that are approved for that, not the tablet. It's also approved for major depressive disorder as an adjunct, and this is one of the most effective boosters you can give. If a person has a partial response to an antidepressant, the first thing I think about if I'm going to add something to improve their response is low-dose Abilify, and you do end up using the lower doses. Abilify is dosed anywhere from 2 to 30 milligrams and sometimes beyond, but as an adjunct for the treatment of refractory major depressive disorder, 2 to 10 milligrams is the usual dosing range. And there are lots of augmentation strategies. I'm going to do a separate video on that, but you could add lithium, you could add thyroid hormone, you can add and combine several other medications in different classes, but one of the most effective, in my experience, the most effective booster for a partial response is to use a third generation partial dopamine agonist. It's also approved for autism-related irritability in children ages 6 to 17 and Tourette's disorder in children ages 6 to 18. It's also approved officially for acute agitation associated with schizophrenia or bipolar disorder in the intramuscular form. So the intramuscular shot that acts immediately, not the depot, is approved for acute agitation in those conditions. But again, it's used off-label for bipolar spectrum illnesses, psychoses of all kinds, and behavioral disturbances in children, as well as dementias. Although there is a black box warning, the use of antipsychotic agents of all classes are not approved for the treatment of agitation or psychosis when you have dementia, because there's an increased risk of strokes and cardiovascular events in those individuals. So what is the mechanism of action of Abilify? It is a partial dopamine agonist at the D2 dopamine receptor subtype. A partial agonist is a molecule that when it attaches to the receptor, it activates the receptor. But it does so only partially. It doesn't do so as much as a full agonist would do. And so dopamine is a full agonist at D2 receptors. When you give a dopamine antagonist, you're blocking that receptor, and so you're blocking the action of dopamine. And the traditional first and second generation antipsychotic agents, medications like thorazine and Haldol and Risperdal, they are D2 blockers. They block that receptor, so they reduce dopaminergic activity, and this is helpful in treating psychoses. It blocks, for example, hallucinations and delusions, or it diminishes the positive symptoms of psychosis. Well, this is a partial agonist, so it's not blocking the receptor, but it is actually stimulating it only partially. And in theory, what that does, it balances things out. Because it's not a full agonist, then when you look at it from the context of what it's doing to dopamine, it is reducing the action of dopamine. When it attaches to the receptor, it is preventing dopamine from attaching to the receptor, but because it's only stimulating it partially, it is actually reducing dopamine output from those neurons. And in theory, it does so when dopamine concentrations are too high, such as in psychotic conditions where we postulate that it's a hyperdopaminergic state. Certainly in drug-induced psychoses like amphetamine-induced psychoses, those are absolutely fueled by the fact that you're increasing dopamine. So if you give a partial dopamine agonist, you're going to reduce dopaminergic activity because you're preventing all that dopamine that you have floating around because of the amphetamine. You're preventing it from fully agonizing that receptor. I hope that's clear. But that improves positive symptoms, and it is an antipsychotic action. But when dopamine output is too low, using a dopamine agonist, stimulating at least partially, increases dopamine output in that context. And that improves the cognitive and the negative and the mood symptoms of schizophrenia or whatever the condition may be. And so what you're doing in that instance is you're actually getting some of the antidepressant action of Abilify because you're stimulating those receptors. The high affinity of aripiprazole for D2 receptors means that combining this medication with other D2 antagonists, the classical antipsychotics, could reverse their actions. And so it makes sense not to combine Abilify with other antipsychotics. Sometimes you have an antipsychotic and it's working but not as well as you want to, and you have to combine it with other antipsychotics. But combining a D2 antagonist with a D2 partial agonist, you're competing there and you can actually reduce the efficacy. However, an exception to this would be if you have hyperprolactinemia, which is increased prolactin levels, which can lead to galactorrhea, milk letdown from the mammary glands. That's a side effect. When you block D2, when you block dopamine at the D2 receptors, then that increases levels of prolactin because dopamine inhibits prolactin. And when you have too much prolactin, then you can have milk letdown, galactorrhea. And if you have that problem, one of the things you can do, you can try to lower the dosage of the offending agent, but the other thing you can do is to add a partial dopamine agonist, which can actually reverse, at even very low doses, can reverse the hyperprolactinemia. And you also maybe get a beneficial effect on the mood, but that proves that Abilify can interfere with the D2 actions of other antipsychotic agents. Interactions that a myriad of other neurotransmitter receptors might contribute to aripiprazole's efficacy, including the D3 subtype of dopamine receptor. It also is a partial agonist at 5-HT1A receptors. That's a serotonin receptor subtype. And that might be relevant at clinical doses. It might contribute to the antidepressant actions of Abilify. It also blocks serotonin 2A subtype receptors, which causes an enhancement of dopamine release in certain brain regions, and this reduces the motor side effects of antipsychotic agents. So there's less drug-induced Parkinsonism with this class of agents. You do see akathisia a lot. I'll talk about that in a second, but this partial agonism at this serotonin receptor subtype helps with the motor symptoms. It also possibly improves cognitive and affective symptoms. Blockade of serotonin type 2C and 7 receptors may contribute to the antidepressant actions as well. So it's quite complicated in terms of all the different subtypes of dopamine and serotonin receptors that it hits. But there are no anticholinergic effects, so it does not do anything with muscarinic acetylcholine receptors. That's very common and it causes all kinds of nuisance side effects. You don't see that with these agents. It also has no antihistaminergic actions. So it doesn't block histamine type 1 or 2 receptors. And that's probably why you don't see much sedation with Abilify. It's possible, but Abilify can be more activating. Dosing, it goes from 2 to 30 milligrams, and some experts will use more than 30 milligrams. For some patients, though, less may be more. Frequently, patients who are not acutely psychotic might actually do better, and they may actually need to be dosed in the lower range, the 2 to 10 milligrams a day range, in order to avoid akathisia and activation and for maximum tolerability, especially in children and the elderly. Due to its very long half-life, aripiprazole takes longer to reach steady state. It takes 5 half-lives to reach steady state. And so when you initiate dosing, it may take longer to get to that steady state level, and it might actually also take longer to wash the drug out because it takes, again, 5 half-lives to eliminate 98% of the medication. So when you stop it, it takes longer than other atypical antipsychotic agents to completely be cleared from the system. Labs are necessary with aripiprazole. And in clinical practice, this is a theoretical risk. I've never seen this medication cause diabetes or dyslipidemia. which is, of course, elevated blood sugar, and the dyslipidemia is where you have either hypercholesterolemia or increased lipids or a poor LDL to HDL ratio, the so-called bad and good cholesterols. That's called dyslipidemia, when you don't actually necessarily have an increase in the absolute value of cholesterol, but you have a bad ratio, bad fractions. But monitoring is still indicated. It's still the standard of care for Abilify. You're supposed to weigh all patients and track their BMI, their body mass index, during treatment. You need personal and family history of diabetes, obesity, dyslipidemia, high blood pressure, and cardiovascular disease. You want to document all of that. And you really want to measure the waist circumference, because if a patient starts to gain weight, if they're gaining weight in their midsection, that indicates that they're also probably accumulating visceral fat, which is very dangerous. So you measure at the umbilicus, and you also take baseline blood pressure, fasting plasma glucose, and a fasting lipid profile. So I send all patients to get baseline labs to make sure that they don't already have some degree of baseline diabetes and hyperlipidemia or dyslipidemia. And then you're supposed to monitor it once a month for a while, and then quarterly for the long term. This medication is approved for long-term use. It's not habit-forming. And when you want to stop it, it's a good idea always to wean any psychotropic agent, any agent that's affecting mood or the mind in any way. You want to avoid rebound symptoms. And so while there's no physical withdrawal, you never want to abruptly discontinue a dose that's significant. You want to bring it down to a low dose before you stop it altogether. No fatalities have been reported in overdose. So it's generally a well-tolerated medication. It's a safe medication. And in clinical practice, we see really the main problem that I see with it is maybe akathisia, which is a motor restlessness. It comes from when you block dopamine. And so since this is a partial agonist at these receptors, dopamine 2 receptors in the striatum, that is an area of the brain that controls motor behavior, motor activity, and that relies on dopamine. So any blockade or partial agonism that blocks the full agonism of the dopamine that you've just got floating around naturally can cause drug-induced Parkinsonism and akathisia. You're competing with dopamine, and dopamine's a full agonist at these receptors. So you can get akathisia, not in all patients, but plenty do get it. So I warn patients about that. But if you start at a low dose and you titrate slowly, you can avoid the worst of that. What are the most common side effects otherwise? Dizziness, which is caused by blocking alpha-1 adrenergic receptors, norepinephrine receptors. That can cause orthostasis, orthostatic hypotension, where you don't get the vasoconstriction that you're supposed to get when you stand up. And if you stand up too quickly, especially if you're dehydrated, you can get very dizzy. You can actually faint. You can actually experience syncope from that hypotension. And so you want to warn patients. Also very common, I don't want to say very common, I want to say the most common are nausea. Any medication can cause nausea, and vomiting if it's to the extreme. Patients can sometimes experience insomnia with it. And so you really think about it if you need a mood stabilizer or an antipsychotic agent, and you want to avoid sedation, because again, some patients are actually activated by it. And we think that all of those side effects that I just mentioned, nausea, vomiting, insomnia, and activation, are probably due to the aripiprazole's partial agonist actions at dopamine type 2 receptors. Weight gain. That's been reported in a few patients, especially those with a low BMI to begin with, but it's not expected. It's certainly less frequent and less severe than for most other antipsychotics, although there may be more risk of weight gain in children. Sedation has been reported in a very few patients, but again, it's not expected. It is much less than for other antipsychotics, but never say never. It's possible, but this medication can actually be activating. Tardive dyskinesia is a condition that's caused by the chronic blockade of dopamine D2 receptors. As the name implies, it is tardive. It shows up late in the course. And so at least a few months, but usually years. and it appears to be dose dependent. This is a movement disorder that involves really classically perioral movements, the tongue and the lips, but it can also involve blinking, and it can involve the torso and the upper extremities. And you can see chorioathetoid movements due to TD, but the risk is reduced compared to conventional antipsychotics, and I consider it a theoretical risk. You still want to review it with patients when you're getting informed consent, because these involuntary dyskinetic movements can be permanent. And sometimes when you stop the medication at the onset of tardive dyskinesia, you stop the medication and the tardive dyskinesia doesn't necessarily go away. But the risk does increase with cumulative dosing and the treatment duration. Impulse discontrol is also a possible side effect. Even though we use this medication for acute agitation, acute mania, you can actually see impulse discontrol because in the context of increasing dopaminergic activity through partial agonism, that can lead to conditions that are known to be exacerbated by increasing dopamine, such as compulsive gambling or compulsive shopping. Also binge eating and sexual activity. So a person can become relatively hypersexual. But if they're already relatively hypersexual because they're manic, then giving them a partial agonist is actually going to block dopamine. There's already too much dopamine, and that actually calms things down as a mood stabilizer. So it's a treatment for hypersexuality if that exists in the context of acute mania, but it can cause, rarely, it can cause hypersexuality through the partial dopamine agonism if there's not a problem with dopamine to begin with. I hope that's clear, but that's what you get when you're talking about an agent that balances dopamine. It increases it when there's not enough of it in a depressive context, in the context of major depression, but it relatively decreases it in the context of a hyperdopaminergic state, such as, in theory, schizophrenia, but also bipolar disorder, and certainly in amphetamine-induced psychosis or amphetamine-induced mania, just to name a few conditions. What about life-threatening or dangerous side effects? Hyperglycemia in some cases can become very extreme and acute, and you can see ketoacidosis, which can lead to hyperosmolar coma, just as you would see in diabetes, and that can be fatal. That's been reported in patients taking conventional antipsychotics, but also in atypical antipsychotics. Rarely, you can also see neuroleptic malignant syndrome, NMS. That is a syndrome that includes hyperpyrexia, high fever, muscle rigidity with muscle breakdown, that's called rhabdomyolysis, delirium, and autonomic instability, so you have an unstable blood pressure. And you also see, because of the muscle breakdown, elevated creatinine phosphokinase, which is an enzyme, but you also see myoglobinuria, so there's a lot of myoglobin in the blood, and that can shut down the kidneys, and acute renal failure obviously is lethal. But it's very rare. You really see NMS more with the conventional antipsychotics. Rarely you can see seizures with this medication. I mean, it sounds terrible, but these are theoretical risks, and we're really talking about the conventional antipsychotics. I don't even warn my patients about these things because you really don't expect them, and I've never seen them. But there is an associated increased risk of death due to cardiovascular events in elderly patients diagnosed with dementia, and so it's not approved for the treatment of dementia-related psychosis. As a class, antidepressants have been reported to increase the risk of suicidal thoughts and behaviors in children and young adults, and so that's listed because as an antidepressant adjunct, it does have antidepressant actions. I don't think of Abilify as an antidepressant, and we don't use it by itself as an antidepressant, but it certainly has antidepressant actions. But this is very controversial about the increased suicide risk. I have another video that I did on that. I, for one, do not feel that there is sufficient evidence that it's actually the medication that's inducing suicidal thoughts and behaviors, but you do see it in young people. Also, rarely you can see temperature dysregulation with Abilify, so hot flashes, and the antipsychotics can cause dysphagia, which is a problem swallowing, and so in theory you would perhaps expect to see this with Abilify very rarely, and more so in patients that may be at increased risk, like the elderly. The potential advantages of Abilify, especially treatment-resistant depression or depression that only responds partially, you think about this. Also, patients who are concerned about gaining weight, patients who are already obese or who already have diabetes or dyslipidemia, especially elevated triglycerides. This class of agents, the third-generation antipsychotics, are only theoretically at risk of inducing these syndromes. Patients who wish to avoid sedation as well are patients that you would want to think about. So even though weight gain and sedation are listed as possible side effects, it's actually those patients who need to avoid those that you would think of when you are thinking about prescribing this medication. I think it's an excellent medication, and patients almost always improve significantly when you add Abilify as an adjunct for the treatment of refractory or partially refractory major depression. Thanks for listening, and please check out my video on Vraylar, which is a newer agent in this class.